Hi, we're back. This is Gerald Major from the Canadian Spondylitis Association, and I'm here with Dr. Claire Barber, and we're going to talk quality improvement and balanced scorecards. Rheumatology, why are you here, and what brought you here, and what's your role?
I'm a rheumatologist and clinician scientist out of the University of Calgary. And what brought me here, I love coming to the CRA every year since I was actually a medical student, and one of the reasons I came into rheumatology was it was a very kind of welcoming specialty, very collegial environment, lots of interesting stuff going on, and got eventually advanced through my career and decided to go into research, but also see patients as well, and got into the field of quality of healthcare. And so that's my passion right now, is driving research projects that try and aim to help improve the quality of the care that's delivered every day to Canadians living with arthritis.
So you have you did a presentation today, so maybe go through the presentation a little bit so the people that aren't
Sure.
here or can't be here can understand.
Sure, okay. So essentially the work that I'm currently doing, along with a team of researchers, including my co-primary investigator, Deanne Mackay, who's a researcher out of Arthritis Research Canada and University of British Columbia. We are developing a balanced scorecard for rheumatoid arthritis. And a balanced scorecard is sort of like a report card, if you will, for looking at how care is delivered, to make sure that we're providing a high quality of care for, again, Canadians living specifically with rheumatoid arthritis. And people often ask, what makes it balanced? Like, why is it, why not just call it a report card? The reason this is considered balanced is that it's looking at different perspectives of care, looking at the care provided from both the patient's perspective, perhaps from an economics perspective, from a learning perspective, and processes of care perspective. And this concept of a balanced scorecard was actually started around in the late 1990s by Kaplan and Norton. Is actually a concept from the business world. So if there's anybody out there who's, might sound like business speak to them, but actually it's been applied in a number of Canadian healthcare settings to date. And so we're looking at, in the study, how to really define the vision, which is sort of at the center of the scorecard, if you think of it sort of a circle with 4 different domains, and then figure out the vision and the strategy to get to the highest and best level of quality of care that we can, using performance measurement, but within these different stakeholder domains. Does that make sense, or
It makes sense.
To have a diagram?
It makes sense to me. I mean, I have a business background, and that's what I did, and then I landed in patient advocacy through illness. So I get it completely. I'm actually very happy to hear it, and I didn't think of it myself, but that's great. So you have, we just finished an interview with Glenn Hazelwood, and back to back we have people that are interested in patient perspectives on things. So maybe talk a little bit about patients and the involvement and what you feel is relevant and valuable.
Yeah, so we have 2 patients who are actually on the grant who've helped sort of strategize about recruitment, as well as help to make sure even the language of everything from our consent forms to the questions that we're asking is relevant to patients. So they're at the inception of our project, which I think has really been key and very eye-opening. And then in order to develop the scorecard, we want patient perspectives on what they think the domains of the scorecard should be, and eventually there'll also be patient involvement in what the specific measures will be. And so right now we've had a few focus groups and interviews with patients about the scorecard during that phase 1 of our project. And again, in the second phase, once we figure out what these domains are, we'll be populating the scorecard, and there'll be patients involved with that too. And then certainly in the final phase of the project, where we're actually testing our scorecard, we're going to be testing it in Calgary in some clinics, there'll be patient input. So we really had patient involvement from start to finish of this project, which I think is really invaluable. Excellent.
My community rheumatologist is Dr. Vandana Ahluwalia, so that's who you presented with today. Yeah. So talk about the what she presented, and then how you kind of overlaid on top. Yeah,
so Vandana sort of set up talking about quality first of all, because there's a lot of lingo involved, if you will. Like, we talk about what is a quality measure, and I can certainly review some of that if it's helpful. And then she also provided some examples of what's happening in Ontario with some of the health, I think it's the Health Quality Council there that's developing some standards around osteoarthritis, but you'd have to speak to her more about that. But really she set up sort of the lingo about the dimensions of quality, what a quality indicator is versus a performance measure versus a standard, that helped to kind of lay the groundwork for me to be able to talk about what a balanced scorecard is and to move.
And so how'd she do?
I think she did great. She's always a dynamo when she speaks, so it's always enjoyable presenting with Vandana.
Did you put her on the scorecard?
Did I put her on the scorecard? I would give her A+.
There you go.
A+.
We spoke briefly just before this about, your research, and has it led you to answers or better understanding of rural areas and Indigenous communities?
So I haven't specifically done research in Indigenous communities. My colleague Gerald Major at the University of Calgary is expert in that area, although some of my earlier work in collaboration with the Arthritis Alliance of Canada was to develop some system-level performance measures, and these capture measures that look at timely access to rheumatology care and timely treatment. And so we tested those in a variety of different settings, two of which were some cohorts that she works with that are run out of, one is out of the Siksika First Nation in Calgary, and the other one is out of one of the urban, sorry, I'm just forgetting the name of it, but an urban center where Indigenous care is delivered. And so we have looked at some of those performance measures in those contexts, and also in other areas. Even there's disparities in our country when looking at wait times and, for access to care. Among the provinces as well. So Newfoundland had extremely long wait times for patients for arthritis care compared to places in Ontario like Vandana's clinic, which was also looked at, and other ones in Newmarket. So there's definitely differences across Canada relating to how patients access care, how quickly it is, how quickly a diagnosis is able to be made, and how fast people are offered treatment. And but if you don't measure it, you don't know.
Yeah, I was going to say, so that's, for me, that's kind of your starting point, and that's step one, is to really kind of understand it, so then to know how you can actually help to solve it.
Yeah, absolutely. I think it's really key. If you don't measure, you don't know.
So we're one step closer, I think, to solving that issue.
Yeah.
Anita, do we have anything from outside? I know Vancouver is pretty much shut down with the snow today.
Yeah.
What is considered timely access to rheumatology care?
So it depends a little bit on the diagnosis. There was an effort in Canada to develop wait times, acceptable wait times, and the CRA participated in what was called the Wait Time Alliance. And so, again, if people had rheumatoid arthritis, it was felt to be 4 weeks, not from the time of symptom onset, but from the time of referral from the family physician to seeing the rheumatologist was felt to be 4 weeks. Unfortunately, what many of us have discovered talking to patients and looking at this more closely is that often the delays are from symptom onset. So in finding the symptoms, getting to the family doctor, having the family doctor recognize that, and that can actually lead to quite a much longer delay, although the performance measure focuses on what we as rheumatologists can probably improve upon, which is that that 4 week window. But so that's why if people have symptoms, they need to get to their family physician and advocate to see a rheumatologist. And the rheumatologist should be doing as much as possible, that they can do to try and get those patients in quickly.
And can you expand more on how important it is to get timely access to care for someone living with arthritis?
Yeah, it's incredibly important because we know that timely access to care improves time to treatment, so people getting timely access to a diagnosis, end up getting treated. Usually, almost always, when we looked at actually time to treatment, once you've seen the rheumatologist, is often the same day. So you get in to see somebody, they recognize it's rheumatoid arthritis, you get treated right away, and we know people that get into remission and treated, promptly end up doing better in the long term. So less likely to have disabilities and pain, or less in that. So it's really critically important to get in there, get that diagnosis, and get on treatment in a timely fashion.
And finally, are there any quality indicator tests that the patients can do themselves?
Yeah, so a quality indicator is more of a test of a healthcare system as opposed to something testing on an individual patient per se. Although with our balanced scorecard, we're interested in the perspectives of patients, so that there might be things about their appointment, for example, that they might want to be tracking or seeing as trends. So that's something we might be exploring. Certainly I know that in our clinic, we're working on a platform called Room for You, where we're looking at developing ways that patients can actually follow things like their trends of pain, disease activity of their joints, which is sort of a composite measure that looks at the tender and swollen joints, as well as some other measures that comes to sort of a single number that can be followed over time to see how patients are doing. Sort of analogous to if somebody had diabetes, they can follow their diabetes number and their sugar numbers, that's something like that, and also their functional status. So we're working on ways that there's numbers that patients can follow that indicate the quality of care that they might be receiving, but it's technically not a quality indicator from a healthcare perspective.
So
if that makes
keeping
sense.
a journal would be helpful, I guess, to patients.
Yeah, keeping a record of what's been going on, so that they can review things with their physician at the clinic to see what changes need to be made. But making sure that they're if they're having pain and flares, or they're having symptoms, to not let things linger, because that can cause damage if left untreated.
Well, I want to thank you so much for making the time to do this.
Super.
And for your attention on quality and patient inclusion.
Thank you.
So thank you very much.
Super.